we are going to look at the another very important topic. Give the 7 star, that is the anatomical snuff box. So you are taking the drug absorbing substance at the base of the thumb and just rubbing it and then snuffing. So this is our anatomical snuff box. Okay, sir. Now look here, sir. There is our entry border. Entry border is formed by our abductor muscle. A for entry, A for abductor. Okay, and posterior boundary, posteriorly there is an extensor compartment. So posterior is formed by the extensor pollicis longus. But remember, one more tendon is just behind our abductor pollicis longus, that is extensor pollicis brevis. So these two are making the anterior boundary. In anatomical position it is laterally, so this is the anterolateral boundary also, while this is tendon of the extensor pollicis longus, which is making the posterior boundary. So another mnemonic, yes, anterior longus, posterior longus, between is brevis. Anterior longus is our abductor pollicis longus, yes, posterior longus is extensor pollicis longus, and in between them extensor pollicis brevis, which is close to the abductor pollicis longus. In cadaveric image practice, can you see this one, sir? This is our anatomical snuff box. Okay, so the entry boundary is formed by the abductor pollicis longus along with the our A extensor pollicis brevis, and this is the posterior boundary which is formed by the A extensor pollicis longus. Okay, sir. So this is our anatomical snuff box. Why it is important? Yes, many clinical points are here. What are the different clinical points? Can you see, sir? Scaphoid fracture is related here, sir. The holding glass holding position is there. Yes, avascular necrosis is there. Intravenous injection site, wristwatch neuropathy, Finkelstein test. So many questions directly, indirectly they are asked. That's why. So one by one, sir. The roof is formed by skin, superficial fascia, deep fascia, and at the roof there is a presence of our radial nerve and our cephalic vein. So these are the utility. Remember, because here is the radial nerve. So compression of the radial nerve due to the tight wristwatch, there is the abnormality along the dorsum of the hand. Yes, along our nerve fiber. Fine. So this is our chiralgia paresthesia, which is also known as the Wartenberg syndrome, which is also known as the, yes, our tight wristwatch neuropathy. That's why Salmon boy aaj gaadi tera bhai chalayega, he is wearing the loose wristband. Very beautiful, very brilliant person. Now try to understand, there is the also our cephalic vein. So cephalic vein is the site for the intravenous injection. You are using the IV drip at the medicine ward. Now see the floor. Floor is formed by, just to see your hand, no need to mug up. Sir, there is our styloid process of the radius. Sir, there is the scaphoid bone. Sir, there is our trapezium, and then base of the first metacarpal. Just feel it, just think it, and you can give the answer. No need to mug up. So you can see the floor is formed by the styloid process of the radius, scaphoid bone, the trapezium, and the base of the first metacarpal. So this is the floor. Now the scaphoid bone is the most common carpal bone which is getting fractured. Why? When we are falling with the outstretched hand, so we are supporting the ground, so the pressure is coming at this part. Okay, sir. So there is a fracture of this our, yes, scaphoid bone. Okay, now try to understand, for this fracture what we will do, we will ask the patient for the glass holding position. Why the glass holding position? Try to catch this point. When we are doing the glass holding position, there is an abduction, and abduction of the thumb, it is causing the alignment of the thumb, first metacarpal bone, yes, our scaphoid bone, and the radial bone. Okay, so these all are coming in one line, that is the our, yes, scaphoid fracture situation. Okay, so this is the our glass holding cast you are using. Okay, sir. Now look here, yes, avascular necrosis. One more thing, scaphoid is having the very peculiar blood supply. So whenever there is the rupture of the blood supply, this scaphoid bone is affected. Getting the point? So this is the our avascular necrosis situation. Remember this one. Okay, sir. The most common site of the avascular necrosis, remember, answer is the head of the femur, neck of the femur. Second most common bone is scaphoid, and third is the talus, orthopedis integration. Very important. Now look further. I told you this all. Yes, one more clinical situation, the Quervain tenosynovitis, inflammation of the anatomical snuff box tendon. Yes, they are leading to the inflammation of the tendon. That's what teno. Synovial sheath is getting inflamed. That's a synovitis. This is the Quervain tenosynovitis. Now look here, sir. There is the inflammation. Sir, what is happening, sir? To test this Quervain tenosynovitis, you will perform the Eichhoff test and the Finkelstein test. You will ask the patient to hold the thumb inside and hold the thumb with the finger, and then ask the patient to deviate the hand in this way. So there is the more pain. If more pain is there, means there is the inflammation of the anatomical snuff box tendon. Yes, it is our Finkelstein test. So remember, do practice again and again. Practice gives perfection. So all the content what we have covered in the 40-50 hours class, we are going to cover approximately the same thing in our 10 hours. So you have to focus over this session.